Assalamu alaikum. I would like first to thank all the people organizing the meeting, and the company sponsoring us for this meeting. Thank you, Dr. Muhammad. I would like to talk about the orbit imaging. I don't know where is the timer yet. It's there. In the situation of trauma, we had a nice lecture by Dr. Noor before on the traumatic situation, but also to consider orbit in our practice. So usually the imaging is decided on the clinical exam. What do you want to see for diagnostic? Then you can choose the different possibilities on what you want to evaluate inside the orbit. And we have also a situation where the imaging is there to guide us and to help us during the treatment, during the surgery. So I will go through all the different situations. Of course, the simple X-ray is sometimes helpful if you have only this one, but you have to learn to read it. And I feel that more and more the juniors don't know to read it because we are not using it daily. Here in this patient, you can see, for example, here an hematoma on the top. We usually do it when we know that there is a foreign body, but we always have to think about for a patient who you suspect to have a foreign body. This patient, you may expect small nail, and you can see that it goes almost to the cranium fossa. So CT scan is the best exam for the foreign bodies, and during the trauma, when it is available in your in your facility, I think after an eye trauma, you have to do that before offering the surgery to the patient for combining at least the foreign body removal and the primary repair. B-scan is more difficult. You need more training. The curve of training is difficult. As you see, for example, in this patient, the CT scan, it's very obvious. Any junior doctor or any senior doctor can see that there is intraconal mass, but with the B-scan, you have to search and to be more, let's say, trained to see the same tumor that is in the backside. So the A-scan is sometimes useful for some vascular lesions into the orbit. We use also the B-scan to analyze the head of the optic nerve and the optic nerve as well. And in this patient, for example, we can do it routinely to see whether the patient has an optic nerve swelling or no. And sometimes you don't have access to the backside of the eye by your usual exam because the medias are not clear. So the B-scan can be helpful, of course, to do it when the globe is closed and no pressure on the globe during your exam. So the MRI is I think, the must for the orbit, to evaluate the orbit in deep. And this is the perfect exam for the soft tissue, vascular. As we mentioned, you need to know the MRI T1, T2, FATSAT, and are different sequences that can help you to observe or to see what you want to see inside the orbit. So you direct your exam. You ask to your radiologist, I want this exam, because clinically you are expecting some things. It's not like you fish large and you say, maybe I will see what is inside the orbit. The clinical exam, your decision is the one who guide the radiologist to give you what you want to see. So we can evaluate the muscles, of course, in the case of Graves' orbitopathy. But not only that, we can, with the sequences, we can see that in the left picture, the medial rectus is wide, inflamed. So we can also use it as a criteria of active stage of this Graves' orbitopathy. We can see sometimes patient with an myositis, where you see the tendon which is also enlarged and inflamed as well. So the MRI can be used to analyze the vasculature of the orbit. It can be venous evaluation or arterial evaluation. We have a patient here with large angioma. You can see whether there is an intraorbital extension or no to define your treatment. And for example, this patient, you have to think twice before offering any sclerosing treatment. You know that there is inside orbit expansion and there is a risk for your optic nerve. So this is a very, very helpful exam in this situation. So you have T1 and T2 that can show you the fat, the mass, and you can see whether it is a vascular mass, it is a regular or non-regular mass, intraconal, extraconal, compressing or not the optic nerve. And as I said, this is the master exam for the intraorbital content. You have sometimes to look at very specific, unusual for us, by the way, as an ophthalmologist, sequences, which is very commonly used for the brain. It is diffusion tensor imaging. You can see in this patient where a normal picture, T1, T2, does not give you any specific information, but you know that there is here a neuritis or a neuromyelitis, an inflammation of the brain and also the optic nerve. And this is very helpful for the neuro-ophthalmology people. We can also evaluate the sheath of the optic nerve. You need to request the proper sequence. You can see here that the sheath of the optic nerve is a bit enlarged. So that's an information to think about intracranial pressure. So we can also evaluate the apparatus of the orbit, which is the lacrimal pathway. So by simple dacryography, here you can see we just inject through the lower or the upper canalicule and see whether there is a narrowing or occlusion of the canalicule. So easier and faster exam to do that gives you anatomical and functional and physiological information, which is the dacryo CT scan, 2 drops of the iodine, and the patient goes to the CT scan, which is fast, and then you can see where is the narrowing and whether the canal is completely open or no, and to, of course, confront with your clinical exam before. Dacroscintigraphy is one of the ways to examine the lacrimal apparatus. It is very useful in kids because they just have to have a picture. You don't need to give a sedation. So 1 drop of technetium and then wait and do sequence pictures and to see whether the canal is working or not before offering treatment. And usually we like to have it after failed treatment. For example, if you do a probing and did not work. So this is an example. We don't ask request, but when you have a patient, for example, here with the IgG4 disease, you want to know whether it's only the lesion that you've seen in the CT scan, the MRI or the CT scan that is the mass of the IgG4, or you can evaluate the full body and the full face of the orbit with TEP scan or PET scan. We can utilize the imaging for planning a surgery. As in this case, you can evaluate the volume, what do you want to remove, how much, and also in this case, you can do a surgical plan before. This is a CT scan that you can incorporate in your machine during the surgery and to know where is the mass, how large it is, and even sometimes it can give you the plan of the shape of the mesh that you are going to utilize after removing the mass to repair this kind of defect. So this is very useful tool. This is part of the imaging, rarely used for the trauma, but still the same CT scan can be used if you have a complex fracture of the orbit during your surgical plan, even if it is an emergency. Thank you for your attention.